Greetings, everyone. I'm Mahesheema, Section Head, Clinical Chemistry and Toxicology at Metro Health Main Campus, and I'm Care Director for Rapid Response Labs at Metro Health. I also serve as an Associate Professor at Case Western Reserve University School of Medicine. Today, I will be talking about improving diagnosis, a study of Siemens Clinitek status versus the ARKRAY AUTION Max analyzer for suspected urinary tract infections. So urinary tract infections is a common infection that can affect any part of your urinary system. The most frequent cause of UTI is bacteria, particularly E. coli symptoms often include a frequent urge of urination, pain during urination, and discomfort in the side or lower back. Most UTIs can be treated effectively with antibiotics. And a UTI is an infection of a urinary system, and this type of infection can involve urethra, kidneys, bladder. The most common question is, how common are these urinary tract infections? So they are pretty prevalent in medical conditions, particularly in women and individuals assigned females at birth. And research indicate that approximately 50% of those assigned females at birth will experience a UTI at some stage in their life. Furthermore, it has also been seen it affects the men and individuals assigned male at birth, as well as children. The incidence in the pediatric population ranges from 1% to 2%. The literature also says that each year healthcare providers administer treatment for UTIs to an estimated 8 million to 10 million individuals. Urinalysis, this test usually it's offered in by giving a special cup where the sample is collected and the technicians will analyze it for the signs of UTI. They will look for various indicators such as nitrites, leukocyte esterase, and white blood cells. Accessing urine is often the initial step in evaluating a patient suspected of or confirmed to have deteriorating kidney functions. Urinalysis is performed to rule out UTI, and the outcome measures is to reduce the antibiotic use. And usually it is performed in the ED settings in the point of care by using a rapid testing and to reduce the need for the lab test. And then at times it's also sent to the main lab, since same thing to confirm. And then from there, depending upon the outcome of the lab results, they are sent to the microbiology lab for the urine culture, where the lab technicians will test the samples to grow and identify any bacteria present. Urine cultures are important because they help the provider determine the most appropriate treatment for your conditions. Let's see the composition of the urine. Usually they are solids which are composed of inorganic components and inorganic components. And the water is usually, the water constituents are usually approximately between 1500 to 1800 ml per 24 hours. The solid components are usually gauged to run organic and inorganic components on an immunoassay. However, the liquid components are run using, tested by urinalysis. And the urinalysis components, if you can see, they are gauged by three components. The first one is the macroscopic examination, or the physical characteristics, where one can determine the volume of the urine. Either it's a random urine or a 24-hour urine, depending upon that, or it could be the color of the urine or the odor and the specific gravity. The second analysis is the chemical analysis, where the different components of the components, if you see on the left-hand side, the pH, glucose, proteins, ketone bodies, nitrites, urobilinogen, bilirubin, blood. And microscopy of sediment, it could be range from RBCs, WBCs, cast crystals, and epithelial cells. The dipstick analysis or the chemical analysis are often performed using the reagent strips that are introduced to the urine sample. Color changes are usually read manual or by strip reader utilizing a reflectance photometry. Alternatively, most elements can be quantified more precisely using chemical autoanalyzers, pH probes, and osmometers. See, if you see on this in the table, the pH is usually useful in interpretation of microscopic crystals, hemoglobin for RBC trauma, enzyme deficiencies, specific gravity or osmolarities, useful in the interpretation of microscopic results, may have pathophysiological significance in concert with other findings, diagnosis of hyponatremia. Proteins, glomerular diseases, glucose for diabetic mellitus, ketones for ketosis or starvation, nitrite for bacterial presence, and leukocyte esterase, pyuria. So the chemical analysis in our lab is usually offered at the ED and by a point of care testing, that is Clinitek status analyzer, and it is also the other analyzers that are used are Clinitek Advantage analyzer, which is also a point of care analyzer. And we have used previously iris velocity urinalysis instrument in our core lab. Now currently we use iris DXU work cell automated urinalysis system. There are multiple advantages and disadvantages when you're using the conventional technologies in the main lab versus the point of care, and this is not new for us. The advantages from using the conventional technologies, it's reliable, sensitive, and it's slightly time-consuming, multi-step, and it's one have to send it to lab. However, in the point of care setting, it's very available and it's fast. The results are out in minutes. It's simple, multiplex, portable. However, the low results reliability and accuracy, low sensitivity, and it's not fully integrated into the practice. Today, we will be presenting a quality improvement project. We got a issue from our caregivers pointing out that the disparity in the leukocyte measurements between the point of care and the core lab test. So the objective is to compare the urinalysis leukocyte values between the point of care and core lab testing. So the method we used here is we used approximately 30 specimens and analyzed both on the point of care and the core lab test platform at the same time. So the point of care analyzer which we used at our facility is the Clinitek status analyzer. It's a semi-automated benchtop analyzer. It is a benchtop analyzer where it offers rapid and reliable chemical testing and screening of urine. And the specimens collection and preparation, it's freshly void urine, and basically the test should be conducted within 2 hours after voiding, and no preservatives are added. So here you can see the chemical test performed utilizing the Clinitek Advantage and the multi-stick 10SG. And the 10SG strips are foam plastic strips to which are affixed with several reagent testing areas that offers rapid and reliable chemical screening of urine. The light reflected at specific wavelength from the test pad is dependent upon the degree of color change in the pad and is directly related to the concentration of the particular constant in the urine. So here you can see basically I would like to highlight on the leukocytes, nitrites, and the blood. It depends upon whether if it is negative, versus trace versus small, moderate, and large. Similarly, for the nitrates, it's negative versus it's positive. And for blood, it ranges from negative to trace amount, moderate, or it could be small, moderate, large. And the time frame is indicated 2 minutes for leukocyte, nitrate 60 seconds, blood 60 seconds. Would like to also highlight, especially since we are considering the quality study for leukocytes, where leukocytes values, they are ranged from small or greater, indicating it's abnormal, and the sensitivity is between 5 to 15 white blood cells. The chemical principle is the reagent strips test for the leukocyte uses an absorbent cellulose pad impregnated with buffered mixture of derived pyrrole amino acids, ester, and diazonium salt. There are granulocytic leukocytes contain esterases which catalyze the hydrolysis of the derivatized pyrrole amino acid ester to liberate 3-hydroxy-5-phenyl pyrrole. This pyrrole then reacts with the diazonium salt to produce a purple color product. You can see that on the schematic on the left side. DXU iris works an automated urinalysis system where it's a fully automated and it's integrated with a microscopy analyzer. And the specimen collection and preparation is fresh urine only and liquid specimens with or without preservatives. That's an advantage, and no strips are needed. And usually it uses the chemistry strip, and that's a very fully automated system. And the strips consists of a plastic strip containing 9 pads impregnated with chemicals specific for the determination of glucose, protein, bilirubin, urobilinogen, pH, blood, ketone, nitrite, and leukocytes. Now, since we are talking about blood leukocytes, and the best part about this automated system is either you can report it out semi-quant or by concentrations. So semi-quant or by concentrations, or you can do POSNIC, depending upon how you would like to do. At our facility, we report semi-quant. And moving on, so the leukocytes, especially on the automated system, it looks like there are small amount of leukocyte esterases which cause positive reaction, and it should be repeated when it's positive, and the grade is 3 if that's indicated as abnormal. And the sensitivity is 25 leukocytes per microliter. And the chemical principle measurement of the leukocyte esterase activity, and in that the indole amino acid, it esterases and hydrolyzes, and then there's a coupling reaction which produces the purple color. So the strip grading comparison, over here I would like to mention about the Clinitek status and IRIS DXU. On the top, if you see the Clinitek status, where it shows trace, small, moderate, and large, and the IRIS DXU, where it shows qualitative and semi-quant. So here on the bottom of the slide, you can see Clinitek status by itself: negative, trace, small, moderate, and large, and then the IRIS DXU, where it is negative, and then they are 25, 75 to 50 or 500 leukocytes per microliter. Now the combined grading system, if you see, we have mashed them to negative, trace, +1, 2, and 3, and the values are 0, 0.51, 2, 3. So we use this grading system, strip grading system, and we analyzed the 30 samples, and we came up with this outcome where the positive, all the 30 samples you can see, and we have seen the IRIS's DXU is shown in the blue, and the Clinitek status leukocytes are shown in green. And using the common grading system for both systems, The 30 specimens are compared across, and you can see that iris DXU is more sensitive to detect the leukocyte esterases. And the test performance agreement between the two platforms. And if you see the nitrites in red, they are pretty well correlated. They are in well correlated. They are, the performance agreement is very good on your nitrites. Coming to the cap urinalysis survey, which we have looked into 2022 CM01 survey, where we have seen the automated system, the leucos, especially we are looking at the leukocyte esterase and the automation system compared to the specimens reagent strip, Siemens reagent strips, the high sensitivity of the test with the auction stick, and the ability to yield a positive results when the disease is present for ruling out the disease. Similarly, we also have looked at the cap urinalysis survey 2022 CM03 sample number, where the negative samples are for the auction sticks and also the Siemens reagent strips. So the high specificity of the test with auction sticks and the ability to yield a negative results when the disease is absent for ruling in a disease. So you can see that by the results of the survey. And then further, we took the 30 samples and we performed an agreement analysis by EP evaluator. The agreement analysis, before we move on to show you the data, I would like to highlight that the agreement between the measurement refers to the degree of concordance between the two sets of measurements used to access the inter-rater variability or to decide whether one technique for measuring a variable can substitute another, or do the methods, two methods give the same results. So the agreement, the percentage of the total cases in which two methods give the same results, the paid results matched by the exact or similar semi-quant grade. So, and there is another one that is an agreement within the two, meaning the paid results matched within one semi-quant grade, which is also a very important indicator of correlation. So here we also saw the semi-quant method comparison to compare the methods that return non-quantitative results. So a study comparing dipstick method for urinary protein to a quantitative method. The results for the quantitative method are divided into two groups corresponding to the dipstick categories, and this approach can be used to compare the semi-quantitative test with the quantitative test. So the key statistics used in the semi-quant agreement, semi-quant comparison is agreement. So I would like to highlight the agreement analysis of the blood, where they are agreeing 70%. However, with the agreement within the two, it shows 100%. And then I would also like to highlight the agreement analysis of the leukocyte esterase. Interestingly, the agreement is 53%. However, the agreement within the two, which is also an important correlation indicator, here we have 83% we have seen, which is very slightly low. And agreement analysis of nitrite, we have seen it's very good. It's 96.6%. And also there is an agreement within the two. This is 100%. Then overall studies agreement analysis of the EP evaluator, we would like to highlight that the leukocyte esterase is 53% and 83% within the two, and nitrite is 96 and 100 for within the two. And then I would like to, there's a literature for the point of care dipstick for the urinary tract infections. So the dipsticks that test for the urine leukocyte esterase and nitrates can serve as a useful screening tool for diagnosing urinary tract infections. And these tests are typically conducted whenever a urinary tract infection is suspected. However, we do not routinely collect urine samples for dipstick testing in young non-pregnant females who have a clear history suggestive of UTI, such as typical symptoms without vaginal discharge or irritation. since the dipstick results usually do not add any valuable information in such cases. In general, dipstick test for the leukocyte esterase and nitrate should not be conducted on patients who do not exhibit symptoms associated with UTI. A positive dipstick results indicating the presence of pyuria or bacteriuria does not confirm a UTI in an asymptomatic patient. So coming to the accuracy, the dipsticks are used to detect the presence of leukocyte esterase and nitrate in urine. The leukocyte esterase, the test is associated with pyuria, which indicates the presence of white blood cells in the urine. It can detect more than 10 leukocytes per high power field, with the sensitivity ranging from 75% to 96% and specificity from 94 to 98%. Nitrite test, a positive nitrite test is a reliable indicator of significant bacteriuria. However, a negative test does not rule out the possibility of bacteriuria. Normally, nitrite is not detectable in urines. The literature has also said in a review there are 6 studies that included female aged 17 to 70 with suspected UTI in primary care setting, where positive dipstick findings, nitrite or leukocyte esterase and blood has sensitivity and specificity 75 to 66%. Another study where it also shows that they conducted study on 66 patients and it has confirmed where the study was conducted on 434 adult patients with suspected lower UTI in a primary care setting were accessed, and 66 patients had confirmed UTI. The presence of nitrite, leukocyte esterase, and blood on a dipstick as well as the clinical criteria were evaluated for the diagnostic value. The negative predictive value was 67% and the positive predictive value was 82%. The authors concluded that the dipstick results can modestly improve diagnosis but cannot adequately rule out infection. There's more literature for the point of care dipstick for the UTI. The 2 systematic analysis and the 4 random non-random studies were identified regarding the diagnostic accuracy or clinical utility of the point of care testing for patients presenting to the ED with suspected UTI. Varied conclusions on the diagnostic accuracy or clinical utility of the point of care testing in the emergency departments were evident. One systematic review suggested that the point of care urinalysis can provide sufficient accuracy in ruling out UTI in low-risk adult females. A second systematic review with the meta-analysis concluded that the rapid urine testing include dipstick tests were not sufficiently sensitive to identify all children with UTIs and cannot replace lab urine cultures. However, the author did suggest that the positive dipstick test should be considered accurate if leukocyte esterase or nitrite was positive. The 4 non-randomized studies assess the accuracy of the dipstick test for the various pediatric population. 3 of these studies concluded that the point of care urine dipsticks provide high sensitivity and showed promising results. One study suggested that the lower sensitivity of the point of care urinalysis must be considered when choosing this test for its rapid turnaround times. Our culture results from the 30 samples have on both the platforms, 23 showed concordance. 8 of these tested positive for the bacteria, 5 cases of the E. coli, 1 case of E. coli with Klebsiella pneumoniae, 1 case of Klebsiella pneumoniae, and 1 case was Staphylococcus saprophyticus, and 1 case was Streptococcus agilative. And the remaining 15 samples showed no significant growth or contamination. We summarize that the sensitivity was 89% for the point of care and 100% for the lab test, while the specificity was 36% for the point of care and 7% for the laboratory test on the 30 patient samples. And in conclusion, we say that the dipsticks to evaluate for the urine leukocyte esterase and the nitrite, as well as the blood, can be used as a screening tool for the diagnosis of UTI. Dipsticks are generally performed whenever UTI is suspected and should not be performed in individuals without any symptoms consistent with UTI. Clinicians should interpret the urine dipstick test results in clinical context that includes patient history and symptoms, especially when using point-of-care dipstick. Urine cultures testing with isolate identification in antibiotic susceptibilities is recommended if clinically indicated. Although point-of-care urinalysis offer more rapid turnaround times, the sensitivity is greater for lab-performed urinary analysis. With that, I conclude. Thank you. Have a good day.